Well, we have, I think, a really strong and important webinar and topic for you guys all today. We've got some great guest speakers, and I'm looking forward to turning the mic over to them so they can share some exciting topics that they're tackling right now and some things they're doing that hopefully will benefit all of us, and then also share a playbook so that other laboratories can use some of the work that they've done to help fight the good fight to open up laboratory network access. So something that's familiar to probably most of you as lab employees, owners, workers, is that it's always a challenge to get paid. There's two reasons that laboratories fail, in my experience, after doing this for 22 years. And those two reasons are: you're either not able to get enough samples in the door, or you're not able to get paid for the work that you're doing. Most laboratories get reimbursed for maybe 65% of the work they do and do the rest for free, which is unfortunate. And we're here to talk about strategies to bring about change. These are a little bit bigger picture macro that we're going to talk about, but we also have some more specific things that your laboratory can do that are just best practice as well. So I have with me today Dr. Sherry Dadgar. Sherry has her master's, PhD, board certified, New York certificate of qualification as a clinical molecular geneticist. She's an academic entrepreneur, a healthcare advocate. She's the founder and CEO of Personalized Medicine Care Diagnostics, a CLIA certified and CAP accredited precision genomics laboratory in Maryland. Recognized by the state of Maryland in 2025 for advancing precision medicine and healthcare innovation. Under her leadership, PMCDX has built one of the nation's most comprehensive precision medicine ecosystems. They offer whole exome, whole genome sequencing, more than 400 next-gen sequencing panels, pharmacogenomics, molecular infectious disease panels, and they serve as a clinical tool, an important clinical tool to reduce adverse drug reactions, prevent reoccurring infections, combat antimicrobial resistance for health systems, community clinics. So Dr. Dadgar also serves as a clinical assistant professor at George Washington University. She collaborates actively with NILA and ACMG, and she leads the Fair Access for Healthcare Coalition. So we're really honored to have her with us today. And we also have our own Ann Lambrix with us, who is the executive director of our revenue cycle management and consulting team, frequent guest here and our resident expert on all things reimbursement. Before I hand over the mic, though, a couple quick things. We'll go through some housekeeping issues. If you're experiencing any buffering, it's probably because you got something going on in the background. So we just encourage you to drop those windows, turn those off. Most common question is always, will this be recorded? How do I get a copy? Good news is you don't have to do anything. It is recorded. You will get a copy. If you registered for this webinar, we will be sending a link to the email address you used to register with a copy of everything we discussed today. So you'll get the full webinar. We also post all of our webinars online on YouTube and on the Lighthouse Lab Services website. So you can go back. Those are always free and look at probably an archive of close to 100 webinars on different topics, and we try to give that information. It's always free to anyone that's attending. We never charge to attend a webinar or to speak on one of our webinars. No need to wait to ask questions either. If you got a question, Sherry or Ann says something that piques your interest and you want to know more about, go ahead and drop that into the Q&A section on the right. We'll be curating and fielding those questions as we go. Probably at the end, we're going to try to leave a little bit of time at the end to tackle some of those. And sometimes we do run polls. You can find those on the right side as well. That's our chance to hear from you and get a little bit of feedback from the audience on this topic as well. A little bit about Lighthouse before we jump into it. The way that we're always able to present these webinars for free is because we provide services to laboratories nationwide. You see our map there of coverage of where our clients sit. We service all of the United States. We've got medical lab directors throughout. Those provide staffing. If you're short on medical laboratory staff, we'd love to talk to you about that. If you have reimbursement challenges, which we're going to get into today, we'd love to talk to you about some of your strategies there. Equipment service is another thing we do, and then just general clinical consultant. You need an LDT validated or assistance with the project, please keep us in mind, because that's how we keep the lights on and keep doing this. So that will be the end of that pitch, and I am going to hand this over to our director of RCM, Ann Lambrix, who's going to talk to you a little bit about payer strategy in RCM.
Thanks, John. I am excited about this webinar today. It's another area that I'm very passionate about, payer contracting and helping our labs and our provider groups get access to the payer contracts and hopefully negotiate good reimbursement. Our team, just a little bit about what the revenue cycle management team does here at Lighthouse. We are not billers. We work with our laboratories, our clients, to and really get visibility into the revenue cycle. And that includes payer contracting, payer credentialing, and identifying the best path forward to make sure that you have the access to the payers and you're getting reimbursed, hopefully at the appropriate rate. And we're helping you with that. We're helping enhance that revenue cycle. And that's what our team does. So we're going to talk a little bit about payer contracts today. I'm going to just high level talk about, again, what we see when we go in and help our labs look to participate and negotiate a contract with an insurance plan. It's important to understand your payer landscape. I always, want to make sure that our labs understand their payer mix. What payers are their top payers? What, when they're receiving specimens, from what payers are those patients, members of? And understanding if it's HMO, PPO, if it's open or closed network, what types of programs do these contracts, these payers utilize to reimburse you for the testing or the services that you're providing. Making sure that you understand, again, the value of what your lab is offering, and being able to negotiate that with the payer is important. So these are just some things, again, to understand, the typical reimbursement methodology and sample rates. I always just explain, are they reimbursing based off of a percentage of Medicare? Do they have their own proprietary fee schedule? Are there different factors that are coming into play? Is lab a potential carve out or ancillary service to the primary service that you're providing? And making sure that you understand that. If you're out of network, what are the challenges of being out of network? Some payers will pay out of network, but it may be because they have, the patient will be dinged with a higher out-of-network deductible. So most likely the payer is going to process and pay the claim, but that doesn't mean you're going to actually get a check. It's going to go to the patient. You're going to have to go after the patient, and that poses challenges in itself. And just making sure that you have some strategy behind payer contracts, payer enrollments, and tackling those strategies and identifying your best path forward. And this is, again, what our team works with our clients on. I know Dr. Sherry is going to talk a lot about the closed or narrow networks and that her advocacy behind helping labs get into those networks. But again, this point is, again, to assess their test menu and being able to approach the payer with the advantage to the payer to have your lab be in network. What is it that you're providing to their membership that may be unique or different than what they're able to obtain from the existing network that they have? So just building that, basically your letter of intent, really having a robust outline of why your lab is special. And that helps with, again, advocacy into these networks and perhaps finding a path forward into being able to get them to allow you into the network. We do work with many pathology groups or specialists that are within, a hospital setting. So the contracts, many oftentimes when we negotiate agreements, there is some leverage there when you are tied to a hospital. If you have an agreement with a facility, the patient is really going to that in-network facility. And so being able to advocate for yourself with that payer and helping the payer understand that relationship and why the specimen, the services are coming to your laboratory. And again, patients, we don't want the patients to get penalized for going to out-of-network laboratory when they're going to in-network facilities. And that's getting into some of this no surprises language, but really being able to leverage your relationships with facilities that may be participating with these insurance plans is very important. Some other things that we've seen be successful when we're advocating for access into payer networks is, if you're able to participate within their quality or risk-based agreement, again, based on the type of service that you're providing, you may be able to kind of counter back with the payer and say, all right, we are going to do a lot better than your preferred lab. We're going to turn around our turnaround times faster. We're going to have better results. Our physicians or our laboratory is going to give better feedback to the ordering clinician. And we believe in this so much. We want to be able to show you, again, that value. And so paying you as a percentage of that, again, quality-based agreement, your language within your contract may read that you have to hit certain quality metrics or turnaround times. And if you achieve it, there may be an additional incentive there. I always, we've talked about this in length on other webinars, but viewing the payer as a client and thinking about, again, you're selling your laboratory to the payer, being able to put together a very robust letter of intent and an outline of what makes your lab unique or special and why there's value there for the payer to want them to have you be part of their network. And then when you're appealing, again, part of a lot of times the process for negotiating or getting credentialing, enrolling with a payer is you submit just an intent. You submit an email and say, I'm interested in being in your network, and you wait for them to respond whether or not they're going to bless that request. And so if you do that and they come back and say, I'm sorry, it's a closed network, being more robust in your appeal and not just saying, well, I want to be in your network, but going through the motions of, again, putting through a very robust appeal letter, outlining the strengths of your laboratory, the strengths of your practice, what separates you from others, why it is important to allow for you to be participating within this network, that detail, and perhaps even escalating it up to someone at a higher level than your initial point person, your provider rep that you're working with, or the credentialing person that you're working with. Getting to that level and appealing and making sure that you're touching all those points will help support that network access. And then, looking at state utilization, where, state and even regional utilization. Again, it comes down to, really presenting your unique value within the space that you're in. All right, without further ado, I'm really excited again to bring in Dr. Sherry Dadgar and have her talk about what she's doing to advocate for a better path forward for laboratories with payers and network access. So,
yeah, thank
Dr.
you,
Sherry.
Anne. I appreciate that perspective. Always good to understand the blocking, tackling side of what we can do. And I think it is super important to remember that the payer really does write the check. And in most industries, the person paying for the product is the customer. And we need to think in terms of what's good for them, not just what's bad for us, right? And so making our case in language that they understand. And I think Dr. Dadgar is going to really take us through some of the different tactics that maybe are working and haven't been tried yet. So some fresh looks at how we can solve this age-old problem. So Dr. Dadgar, I'll give it over to you. And I think you're on mute. Just
the first technical challenges.
there we go.
Thank you so very much for having me, John and Lighthouse. Privileged to be here, really addressing the main issue that we are facing in industry, which is, to me, is a very important issue that impacts patient care directly. I would like to disclose that this is not a paid webinar, and with mentioning that, I would like to basically say that what's the problem? So we all know that what is a problem. Often we, as independent laboratory services or entity, when we are submitting an application to the payer to get in network with them, we hear that the network is closed, or we do have other vendors that are already have agreement with us. Obviously, diagnostic services are very important for patient care, and solely because 70% of all healthcare decisions are based on test results that we produce in our clinical laboratories. It is important because the fact that many of the independent laboratories cannot get in network is a critical issue, solely because we are limiting patient access to the essential diagnostic that is important for their care. And this issue particularly affects underserved area and underprivileged population and rare disease, and those population that are going under recurrent infection. So it is important to address this issue as a collective. Other indications of not being able to get in network is delayed diagnosis, that is well established through different nonprofit organizations, like how delayed diagnosis can impact patient care, which again is one of the areas that we would like to emphasize on today. So there is really a need for calling for action. And when I say calling for action, I really urge everyone, any stakeholder, to collaborate on this issue with us. And that includes patients, includes all the independent laboratories that are involved with providing care to patients directly. It includes physicians who care for their patients' health and want to take an advantage of some of those advanced diagnostic tests that is not available in other lab routine basically setting. It is important for the government legislator whose goal is to really foster biotech health and growth and innovation. So as I said, some of the major consequences of not being in network and therefore not having an access to advanced diagnostic is patient care. It does create a significant delay as far as diagnosing patients. It does impact the hospitalization readmission, and unfortunately, it creates the diagnostic disparities between different populations. Exclusion network practices can increase the healthcare costs, especially for Medicaid beneficiaries. In those states that are basically the Medicaid beneficiaries are managed by managed care organizations. So, reporting 2022 showed that the states that are where the managed care programs are taking enrolling Medicaid beneficiaries, that proportion is very high. For instance, in the state of Maryland, we have about 80% of the Medicare beneficiaries that are under managed care organizations. There were studies before showing that timely diagnosis access reduces hospitalization by 40% and can reduce the emergency visits by nearly 50%. We know that according to CDC, there's about antibiotic resistant and recurrent infections are one of the major threats for the public health. They're about a cost for managing those individuals is about $4.6 billion every year. And that was a report that was in year 2019. Having an access to early diagnosis will be able to help to mitigate some of these unnecessary medical costs. Early diagnosis also showed to improve the antibiotic selection, and therefore it helps to prescribe a right medication for the patient, and therefore avoid or prevents those antibiotic resistant colonies. Other areas of diagnostic that is not easily accessible are whole exome and whole genome, and rare disease setting where we have data showing that, sorry, what did I do? The slides are gone.
No problem. I'll get them back up here.
Sorry. Some of the description on the bottom of the slides are covered, so I tried to recover those.
Yeah, I think that you're right in making the issue not, even though to us as lab owners and lab, advocates, just that not getting reimbursed is a problem for us, but what does it mean for patients? What does it mean for access? And we have to always be framing our conversation in that way, because really we're on the same team as the payer there, right? We want good clinical outcomes for the patient, and we really need to tie any argument or case we make to why opening up network access is going to provide better healthcare outcomes for the patient. And that might be because there's closer care to the patient that's able to be delivered. And so looking forward to you finishing that up and talking about some of the things you've done in Maryland and we're seeing in Tennessee and Kentucky that could be an interesting strategy play for labs to get these networks opened up.
Absolutely, John. And to your point, many of the independent laboratories are starting an independent laboratory to bring an innovation to the society, right? We all come with a novel idea to establish this or to build this or, bring an addition or innovation as far as diagnostic or even like drug development. We all come with the goal to provide patient care, more efficient patient care through innovative approach, and not being able to make those tools that we create to advance patient care, and then because of solely not being able to join the network, that itself is a major issue. Going back to the slide, there was a study showed that exome and genome sequencing not performing exome and genome can delay the diagnosis for average of like 5 years, and which then patients have to go through more than 15 unnecessary tests, which can, by just performing those tests and make those available for patient, you can decrease the cost up to $10,000 per patient per year. And the examples like this is ongoing because of the time limitation. I only put a few ones that I thought potentially would be important. Next slide, please. So care disparities, we did talk about that. Unfortunately, patients who are privileged enough to have, mainly the commercial insurances that are offering PPOs do not face this issue. This network access limitation mainly impacts the population that are either underprivileged population that have financial difficulties, the populations that are living in rural places, rare disease community where the access to the diagnostic tests are a major barrier. So there is a cultural diversity in healthcare that must be acknowledged and addressed. So fair network access issue, again, it's the same concept. What's happening is that managed care organizations that are, as well as some of the Medicare Advantage plans, are managing the beneficiary plans for those patients. And unfortunately, what we face in our field is that they have closed network. When you submit an application to get in network with them, they mainly say that the network is closed. Often they have exclusive agreement with the other labs, but the problem is that many of those larger corporates that they have an exclusive agreement with, they don't even offer this innovative test that the smaller, more local or mid-sized independent laboratories offer. Communication is poor with these managed care organizations. We've, at least my lab, we've tried several times to pass the message that these are all innovative, novel tests to advance precision medicine that all have clinical utility and medical necessity. It's going to help the patient, but again, the communication is poorly facilitated, and we did not have any success with that. Obviously, it is impacting as a result. Any industry that is independent laboratory industry will be impacted by that because the market is solely closed to all those independent laboratories. And this is very unfortunate because we're all coming with the goal and we're all coming with the mission to provide a patient care. But when we get to the stage to go through the licensing, accreditation process, all those steps that are necessary in order to provide a clinical test to patient, then a lack of access to network and payer insurance is a major barrier where it stops us. So many labs, after COVID, as you may know, many labs have shut down because some of those barriers for getting paid through insurances did not exist during COVID. And but however, after COVID, many labs are basically do not have an access to network, and therefore they have no choice rather than closing their laboratory. Another big impact is the fact that as we talk, many of the independent laboratories are launched by academic entrepreneur or researcher or scientists who are coming with novel ideas. And therefore, because of all these issues, if the industry cannot survive and stay stable, therefore we're not going to have innovation in many auxiliary of healthcare, including diagnostic. There are some states that are heavily focused on biohealth growth, and a major impact of job reduction and job growth in those states are also a consequence of many labs that will not be able to get a network.
Yeah, I found whenever I've had a chance to have a conversation with a representative that they do view things through a local lens. And so once you start making it real and bringing a laboratory that's in their jurisdiction to them, that's going to be harmed by this, jobs that are going to be lost, they want to view themselves in their districts as innovative hubs where life science, technology, which is a really clean jobs, are growing and happening. And so I think those are the keynotes if you ever find yourself in a conversation, audience members, with someone to make an advocacy push is trying to make it local to them, why it matters to them as well.
Exactly. That is exactly correct, yes. So again, there's a risk of if we don't take any action. We're really calling for all independent laboratories to help us to address this issue. And as a society and community, I think that it is important also to involve patients and rare disease society to help us to raise awareness and be able to make progress for this initiative.
Yeah, I think I always think of it as like you're kind of walking upstream and constantly need to be fighting this fight. Otherwise, the default is the big laboratories consolidating and just pushing small independent labs into irrelevance. Like we have to constantly be raising the flag and showing the importance of laboratory medicine and the innovation that small labs bring, the access that they bring.
Exactly. And this is violating with the fair provider principle that already exists. I'm sure that everyone have heard about like any billing provider, and that means that any patient or providers should have an option to send their test or get tested at the provider that is their choice. However, a limitation or lack of access to some of these tests is what we are facing within the industry, and it's a clear violation of any billing provider act.
I think this is a really interesting angle to make it connected that the laboratories are a healthcare provider. And that we should be included in that, because I think at first pass, a lot of people read this as a physician practitioner, and the more we can broaden that umbrella to show that we are healthcare providers as laboratory employees, that's a great angle to take.
That is exactly correct, and that's one of the models that we're going to discuss later, where Kentucky recognizes independent laboratories as a provider. And the labs that are located in Kentucky do not they still face other issues, but at least they have more, sort of like opportunity to get a network with payers. Next slide, please. So we were just talking about that. Fortunately, there are some successful, models at the federal level, where in the state of Tennessee, they passed a bill that allows or opens the network for any qualified laboratory to get in network with payers with the same conditions as the other labs. And the state of Kentucky, there was a provision that explained the independent laboratories as a provider. And this basically is varied by state. Some states do recognize laboratories as providers. So in those states, there's less challenges to get in network. You still have to negotiate with payers that, I'm provider, please allow me in. In other states, it's almost impossible. I'll give you an example of the state of Maryland, where independent laboratories, clinical laboratories, are considered as a vendor. And because of that, we have a hard time to get in network with the insurances. So again, we are fortunate that these two models already exist. So we can always, it doesn't matter which state the lab is located, we can always try to communicate with the legislator in that state and try to basically bring those models as an example, good, successful examples, and basically replicate the same model in our state. So, and obviously, these need a bipartisan support. So, fast approach is, again, in any state that you guys are located, if there would be support or communication with the legislator to change the classification of your entity to provider rather than vendor. That would be the fastest approach. There is a longer approach, which is legislative support that needs to be done there, and that probably takes longer. But the strategy that we have as at Fair Healthcare Access Coalition is to approach both strategies at the same time and make changes. Next slide, please. There are some federal recommendations. We want to propose a Fair Network Access Act for laboratories. We do need to bring modernization regulation that basically updates existing policies to reflect current needs in the society. There should be a clear and transparent protocol for the basically payers of like who they can or they should open the network access to. And we would like to propose to CMS to basically supervise the fair practices in each state. Next slide, please.
Yeah, I think this is a great point too, that even when we fought the FDA LDT issue, a lot of the points they were making were things that I think as laboratory professionals we heard and saw also as an issue of like, we do care about clinical values and making sure accurate test results are reported. We're not looking to have less regulations to make sure those things happen, but we just want to be able to do it in a cost-effective manner, not full of bureaucracy. So modernization of CLIA helps with that, right? So that we're not constantly tripping on them pointing out, hey, we need more oversight. Let's go ahead and bring that in. Let's modernize CLIA, which was written in 1988. Let's make it reflect today's world and whole exome labs and next-gen sequencing and patients wanting access to their information. Let's bring those regs up to today's standard. We're not against that as an industry. We want quality lab testing results. Is something we need to continuously make sure that everyone knows.
Absolutely. Yeah, and then fair access, I would like to introduce everyone to FHAC, which stands for Fair Healthcare Access Coalition. This entity has been founded basically to address all of these issues that we discussed. So the goal is to provide support for independent laboratories, as well as protect patient rights and providers' rights in order to improve health outcome for everyone. Next slide, please. Here's the website for this coalition. I would encourage everyone, please, to visit this website. There is a petition that we would like you guys to, endorse. That would give us more stronger evidence or like more powerful negotiation with the payers or a legislator to take it to the next level and address this issue.
Yeah, we need as many people signing on as possible. So if your laboratory is suffering from being shut out of network, you want to make a difference here, please sign on to this petition. We'd love to have a laboratory in every state. That enables us to better do advocacy efforts with representatives in those states. We also want to hear specific examples too. So if you have specific examples of how being shut out has negatively impacted patients in particular, those are things that are great talking points for us, and so we'd love to hear those. But I hope you'll follow this by clicking Learning More and signing on to the petition.
Absolutely. John, do you want to take a lead on this slide?
Sure. The path forward. So yeah, action steps. I think we've covered some of this. We want some of those patient stories in particular. So let's make it specific. If you have examples, that's just a way for us to have a real conversation and take it from being bureaucracy to impacting real people. Joining the advocacy effort, signing on, letting us know that you want to be part of the fight is also really helpful, because we want to know who our allies are out there that we can lock arms with. And as we need to make cases in certain regions, it's good to know who's out there. And recording your denial instances, let us know, keep track of that, because those are going to be part of how we make that case and how we show that there's unfair practice in the way that this is being handled. So, collect that information, and if you're willing and able to share it, that's going to help us build the strongest case possible.
Absolutely. Endorsement from the provider who are using your laboratory service. The letter of endorsement saying that your service, your lab service could improve their patient care. A letter from patients directly. In the dossier of the denial records, obviously that's important too. But yeah, we do appreciate your support. I did put an email address in the chat box. If you want to share your story, if there is any, opportunities for collaboration, feel free to send an email to the email in the chat box. With that being said, thanks so much for having me, John.
Yes, thanks for joining us, Sherry, and making us aware of some of the things you're doing. We appreciate the fight you're fighting, and also your willingness to share that playbook and what's working that you've seen with others, because I think there is a tendency to complain about this issue without doing a lot. And so we hope that more of you will consider, at a minimum, signing on to this petition, being open to being reached out to if we have efforts that are in your region. And best of all is if you can start sharing your story too. So if you can start sharing and sending letters on to your representatives, signing on to this letter, that helps us to make the case better.
Absolutely.
And so I see, just question-wise, it looks like some people are asking about the PowerPoint. Yes, it will be available and will be sent to you, so nothing further that needs to be done on that. Sherry has included an email address for you guys to share some of those stories. And yeah, we look forward to seeing those and hearing them, and we're hoping we can put together a critical mass. Like I said, I'd love to see representation in all 50 states so that we can really have a national appeal here to why access to lab testing needs to be opened up beyond just the few labs that the payers are choosing.
John, do we want to try to field a few of the
Q&A? If you have a few
yeah.
questions, let's see.
Yep. Under Q&A with published, I think there's a few up top that might be easy to
Sure.
check.
I'll throw one out there for us to chew on. The problem with payers like Anthem Nevada is they don't want other labs to be in their network. They just want LabCorp. We did peer-to-peer with them, and it turned out to be nothing. This is from Lister. I think this certainly is not a problem that's isolated to that group, and we need to start thinking about why, right? It's easier maybe for Anthem to deal with one or two laboratories, but if we can start to demonstrate to them that it's not in the best interest of their patients, is where we'll start to make a difference. I don't think there's a lot of sympathy for the fact that it might not be good for your laboratory, but I do know that providers are trying for best healthcare results at the lowest cost possible, and we need to make our argument in that language, showing why their patients need access, they need better turnaround time, what's the impact of having better turnaround time and a better diagnosis in terms of long-term healthcare outcomes. I don't know if Sherry or Ann, you have anything to add on that one.
I would like to add also, many, as we discussed, many of the tests that we younger generation independent laboratories have are really not reproducing LabCorp request service. We all have an additional or more advanced diagnostic test. So if you can, elaborate that message to the payer that my solution is an addition of what LabCorp and Quest offers, that might be useful.
Absolutely. I got a question from Jorge Sanchez here that might be a good one for you, Anne. Are Medicaid MCOs required to reimburse Medicaid credentialed labs, even if the lab is not contracted with them? So this is that credentialing versus contracting, and this is language that trips me up all the time. So maybe you can give us
and again, it depends on what state you're in. There is no requirement in most states for the MCO to contract with an entity that has a straight state contract. So the answer is no, unless, again, you're in, let's say, Tennessee, where there is that law that supports any willing provider.
Mm-hmm. All right. We got a question from Nicole. When you say appeal, do you mean legal counsel or send a simple appeal letter that shares why you're appealing the decision? So I think, Anne, you had mentioned an appeal letter in yours.
Yeah, I think, and I saw this question. So I would bring legal in if there is, you are being denied access to the network and there is a law on the books or in a contract language that allows or says that the payer is required to offer you. Again, I will reference the any willing provider law in Tennessee. There is a law in the books, and if you are in Tennessee, and I found out Kentucky as well, you should be reviewing that law with your attorneys. And if you are denied coverage, then I would have an attorney send a letter. But typically, from my standpoint, an appeal would be the extra, your dossier with very robust information. And that could be from, your clinician, your patients, and really, documenting, as I kept saying, what makes your lab unique in your area. What are you testing for? What's your turnaround times? That doesn't need to be from a legal perspective. That needs to be more from a clinical patient care and coverage perspective. Dr. Dadgar, do you agree?
I absolutely agree with you. Yes, exactly.
All right, we got another one from Jeanette that's more about the reimbursement rate, which is a little bit of a separate fight, very intertwined. As we crafted today's webinar, we thought about this, and I feel like these things need to take place in serial. We need to secure access for laboratories to be able to provide services, and then we can fight the fight on reimbursement a little better. But her question was, how do you combat payers that contract at such a low rate, even in a state where Medicaid has the regulation for most favored nations? Payers don't care, but it's the lab that is held liable for violating that regulation.
And I think that, again, that's the challenge, is even if, we're allowed access to the network, then the other problem is the rates are terrible. And so, that's why I'm excited for this continued advocacy. That is definitely the fight, is getting the access. And then, really, from my perspective, when you get that access, understanding that reimbursement and making sure that you're not just necessarily signing the first offer. It goes back to, negotiating a rate, and what value does your lab provide that these, potentially the other labs that are accepting these lower rates, it's more of a volume for them. It's not, necessarily going to impact them at 60% of Medicare, but it will impact you. And so making sure you have good talking points as far as that reimbursement and what it means for your lab, payers will negotiate. sometimes it's not going to be the rate that you necessarily want, but very oftentimes it will be better than their first offer. So building out that case, including, I just keep going back to your value, why the payer should want you to basically be around, that they don't want your doors to close, and therefore you need a better rate. You can't accept these lower rates because you're not going to be doing as much volume. Anyway, that's how I would answer that question.
Yeah, and I think there's a bigger macro level fight to be had on reimbursement, and we need to do a better job as an industry doing the health economics of why laboratory testing is so valuable. Sherry, you'd mentioned 70% of medical decisions made based on lab data. About 2.6, I think it is, percent of healthcare spend is on laboratory. I think you can make the case that the best dollar you spend in healthcare is on the laboratory test, and we need to start connecting that to outcomes. I think the better we can do at building the body of evidence for when you test and perform these lab tests early, you avoid long-term negative outcomes by catching things earlier. And we can do the economics of how many $3,000 a night hospital stays are avoided because of $70 tests. That's where you start to speak the language of the payer. As an industry, we haven't done that well. And so we're entering an age where I think medical records and lab data in general, healthcare data, is becoming more digestible. And we're going to start to see healthcare insights come out of that. I think a lot of those insights could be that more laboratory testing is needed, and there's better outcomes when those are followed, those care pathways are followed. But we need to invest in that and build those white papers and the body of evidence, because it's just going to be gobbled up by AI bots and things that need to make decisions. And the more that we can guide and influence those decisions through data and just making the case for why lab tests are needed, I think the better our fate's going to be.
And John, to your point, I would like to add only 1% of Medicare cost goes toward diagnostic, just 1%. 1%. And if we can all, and that's the value of like working together as a group, and share information. If there's cost-effectiveness approach that we can use to convince payers that the laboratory test that we offer is really going to help you to save cost, that I think is a key for us to have more negotiation power as far as the schedule fee with payers directly. But yeah, that's a separate issue. Hopefully we can, address each issue, go a tier based and address the first issue, which is getting the network, and then talking about the, reagent costs and how we can all together again convince payers and come up with a solution to reduce reagent cost.
Absolutely. Always a lot of fights to fight, but I hope all of you guys will continue fighting and join the coalition as we seek to make it better for patients and for laboratories. So thank you for joining us. Thank you, Sherry and Ann, for giving us your time and your wisdom. And thank you to all of you for giving us your lunch hour. So we hope you'll come back, and we wish you a great rest of your day.